Okay, go ahead.
Hello, doctor. Greetings from Orchidia Pharmaceutical. I hope you, your family, and all your beloved ones are safe and in good health. Based on your trust in Fortimox in managing ocular bacterial infection and post-operative cases, today I'm going to talk about the outstanding and unique combination Fortimox Plus, which is prescribed for ocular surface infections combined with inflammation as bacterial conjunctivitis and lid infections as chalazion, stye, and blepharitis. Also, Fortimox Plus is the safest combination because it's a self-preserved ophthalmic solution with less side effects on IOP. Thank you for your time.
دكتورة هبة اتفضلي ممكن نبدأ دلوقتي.
أشير السكرين.
Yes.
Good evening, everyone. It's 9 p.m. Cairo time from Mike, the Memorial Institute Kids Eye Center. We are going, inshallah, today for the second online grand round from Mike. We have a great panelists. We have a great collection of cases. Today we have two sections. The first section will be about pediatric glaucoma, and the second section will be about strabismus. For active interaction and rich discussion, kindly use the question and answer tab to ask your questions. Okay, and we will answer your questions. We want to thank Orchidia for sponsoring our event today. And now, let me introduce Dr. Heba Mitwalli. She is a board member of Mike. She is a consultant of pediatric ophthalmology and strabismus in Mayor since 2014. She had a master of ophthalmology and master degree. She had the FRCS. She had her fellowship in Maghrabi Eye Hospital, and she is consultant there now. She joined Mayor in 2012. She established the pediatric ophthalmology unit in 2013. She is also my great mentor, and she is a great pediatric ophthalmologist. Good evening, Dr. Heba.
Good evening, Mustafa, and good evening for you all, for all the attendees. Good evening, Dr. Dwidar, and good evening, Dr. Zainab. Thanks, Mustafa, for your kind words. I'd like to welcome you all to our second Mike Grand Round online. We are always so proud of all our new and young generations, and so we care to present all our young generation to the whole world. And this is the second day we would present you all to the whole world. We are not working alone. You are the assets and the assets of the mic. And so good luck for you all today. Thank you, Mustafa.
Dr. Zainab, good evening. Dr. Zainab.
Good evening, Dr. Mustafa.
Dr. Zainab is a consultant of pediatric ophthalmology and strabismus. She spent her residency in Al-Qasr Al-Aini. She had a master's degree from Cairo University. She had the clinical attachment at the James Cook University Hospital in United Kingdom.
Thank you, Dr. Mustafa.
You're welcome, Dr. Zainab. Dr. Ahmed Dwidar, I kept you to the end because we will start with your session, with the pediatric glaucoma session. Dr. Ahmed is a consultant of glaucoma at Mayor. He is a former associate consultant of glaucoma at the National Guard Health Affairs in Riyadh, former glaucoma specialist at King Abdulaziz University Hospital. He is the best teacher in resident training program 2014 from the National Guard Health Affairs, and he is a fellow of the Royal College, Glasgow, since 2005. Good evening, Dr. Ahmed.
Good evening, how are you?
Let's start with your session, inshallah. Let's go now. We will start with our star, Dr. Nader Mumtaz. He is a fellow at the Memorial Institute of Ophthalmic Research. He is a member of the Royal College of Surgeons, Edinburgh. He got his Fellowship of International Council of Ophthalmology, master degree from Cairo University. He is interested in the surgical management of adult and pediatric glaucoma, and he recently published in the British Journal of Ophthalmology. Dr. Nader, good evening.
Hello, good evening, Dr. Mustafa. Thank you for your words.
Let's go straight to start with your case.
Okay.
I will stop sharing my presentation.
So good evening, all the professors, doctors, and colleagues from Egypt and from all over the world. Today I'm presenting a rare case of steroid-induced glaucoma that's rare in children, and this case is extremely rare that we have just seen it at the Memorial Institute Kids Eye Center, MIC. I do not have any financial interests, so we start by receiving this case and documenting this case of an 8-year-old child from Aswan, came with recurrent respiratory tract infections, and his mother was saying that there is redness, tearing, and eyelid forced closure since birth. What she said that there is a lesion, what's called a membrane. This is the picture of the membrane. This is a disfiguring membrane causing thickening of the upper and lower lids bilaterally. He was almost using prednisolone acetate eye drops for approximately 7 years. Other eye drops like getafloxacin, Nepafenac, and eye lubricant, and full anti-glaucoma medications in the form of combined brinzolamide timolol maleate eye drops, travoprost, and he used brimonidine recently. This is the picture of the child. This is really a painful picture of this child. So we are facing a case of bilateral membranous conjunctivitis affecting the palpebral conjunctiva. There was a question whether it was a true or pseudomembrane, and we will know later in the presentation. On examination, we found that there were corneal ulcers and erosions in both eyes. We tried to measure the vision. Visual acuity was 360, that does not correct bilaterally. And we used the iCare 200 tonometer to measure the IP because it was very difficult to measure it by Perkins, and it was 32 millimeters of mercury on the maximum tolerated medications. And we confirmed the measurement by the tonopen. We are aware that the iCare increases the mean IP by 2.3 millimeters of mercury than the Perkins tonometer. And upon fundus examination, there were advanced glaucoma scooping, almost 0.9 bilaterally. So this is a case of steroid-induced glaucoma secondary to ligneous conjunctivitis, to the use of eye drops. Ligneous conjunctivitis in the literature is reported in less than 200 cases. It's a rare form of chronic conjunctivitis. As genetics may be an MCQ question, it's autosomal recessive, and we will know why I'm stressing on the hereditary autosomal recessive. It's bilateral, causing wood-like fibrin-rich pseudomembrane. This disease is sight-threatening as it causes glaucoma, as this case. Also affects the cornea in the form of corneal scarring, vascularization, infection, or even melting. It's also a life-threatening disease because the development of ligneous membranes on mucosal surfaces can cause death if blocks the tracheobronchial tract, for instance. This case is extremely rare as it's not reported at all in the literature, a case of ligneous conjunctivitis with congestive dilated cardiomyopathy. And that's why it was very difficult to do a general anesthesia for such a child. And we need only one session, one surgical procedure, so that to cure the glaucoma and the ligneous membranes. The etiology of such condition are mutations in the plasminogen gene, and this is because of the deficiency of the plasmin-mediated fibrinolysis, the type 1, the quantitative type of the plasminogen deficiency. I'm going to talk about the pathophysiology because this may affect our decision to treat this patient. Usually, this starts with the minor trauma, the words in red, activating the wound healing cascade, and then fibrin matrix deposition. At this stage, the plasmin degrades the fibril clots, but this is not the case here due to the plasminogen deficiency. So the fibrin will be the same, and upon surgical excision, this will exacerbate the inflammation, causing more and more formation of pseudomembranes, and then this is a cause of trauma that will activate the wound healing cascade, and then a vicious circle occurs. So what's the decision? What can we do? Maybe a question to the Paul.
Karim, bring up the poll.
We need to know what are you thinking of? What to do for this patient?
For active discussion, dear attendees, kindly share with your opinion in this poll. Dr. Ahmed, I will ask you about your opinion at the last of Nader's presentation.
Okay, Dr. Mustafa.
Okay, Karim. Thank you, Karim.
Well, most of the results are for the trabeculectomy, 41%. Yes.
Yes.
The second, the same deep sclerectomy and cyclodestructive procedures, glaucoma drainage devices, less, and the least is laser trabeculoplasty. So let's talk about this with sharing the ideas with all of the audience. Using laser trabeculoplasty in children, and in this case, it's very difficult to insert the gonio lens due to the Lignus membranes. And if we treat the glaucoma, what will we do for the Lignus membranes, this disfiguring and causing the corneal erosions and scars? Trabeculectomy, deep sclerectomy, glaucoma drainage devices, or even cyclodestructive procedures are all invasive for this child, and they will activate the wound healing cascade, and then the fibrin will come. And trabeculectomy, deep sclerectomy, and other devices, or even cyclodestructive procedures will be too invasive for the child. And what about the follow-ups with the membranes? So, our MICI protocol for such cases, we did almost 3 cases till now. We did surgical removal of the Lignus membranes, followed by amniotic membrane transplantation, and we used hourly heparin eye drops. We do not have the commercially available the hydroheparin eye drops here in Egypt. We use the ampoule of heparin that's found in the operation rooms, and this paper is saying how should we prepare the heparin eye drops. If you have 5,000 international units, this will be perfect. You can take it by the syringe and then inject it in sterile drop bottles. But if there's 10,000 international units per milliliter, it can be diluted using the saline to a concentration of the 5,000 international units per milliliter, and then pack it in sterile drop bottles like that of eye lubricants or something like that. And for the glaucoma, we did the least invasive procedure found nowadays is the micropulse transscleral diode laser cytophotocoagulation. And here is our device. This is the intraoperative picture of the child. This is the amniotic membranes after removal of the Lignus membranes, and this is the sutures away from the cornea. The amniotic membrane transplantation was first described by the Italian Barabino and his co-workers, published in the American Journal of Ophthalmology since 2004. He first reported how to use amniotic membrane after removal of ligneous membranes, and the use of heparin in this huge study used for almost 5 years, and we use it till now. The child we operated 1 year, and we used the heparin hourly for the first 2 weeks, and then 5 times daily for 1 year, and it did not recur till now. According to the follow-ups, at day 1 the IP was 18 millimeters of mercury. At day 8 the IP was 13 millimeters of mercury, and after 3 months the IP was 17 millimeters of mercury. Until now the IP did not become higher again. So our messages in the era of COVID to stay connected messages that ligneous conjunctivitis is a sight and life-threatening disease. Variable treatment options are available, but with high recurrence rates. A novel technique of surgical excision with amniotic membrane transplantation, followed by topical heparin, may be the most effective. Micropulse transcleral cytophotocoagulation is an efficient, non-invasive glaucoma treatment that achieves a sustained IP reduction. And thank you so much.
Thank you, Dr. Nader. Thank you so much for this interesting case.
Thank you.
And I have a question for you.
Okay.
You said that ligneous conjunctivitis is life-threatening condition.
Yes.
In your patient specifically, do you have a life-threatening disease or something?
Yes. He has an elder brother who died from the recurrent respiratory tract infections. Most pediatricians are not aware for this condition, and we told them that this was because of the ligneous membranes that closed the tracheobronchial tract, causing the sudden death. And also this is the second child having the condition. I received
Second child, you said it's an autosomal recessive condition.
Yes. So we consulted their parents to do genetic counseling, and we already have the genetic center at Mike, and we are investigating this nowadays.
Thank you, Dr. Nader. Thank you so much for your
Thank you, Dr.
interest.
Mustafa. Thank you so much.
Dr. Ahmed, you choose the cyclodiode.
The micropulse, actually.
The micropulse cyclodiode. Do you usually use it for cases of steroid-induced glaucoma in children, or when do you use it?
In such case, especially as Dr. Nader said, for doing TRAB or deep sclerectomy or glaucoma drainage device, we need a fresh and a healthy conjunctiva in order, because all of these surgeries needs a bleb. So in such case, we will induce trauma, and the membrane will fibrose the conjunctiva, and it will fail, and it will be like nightmare to close even this conjunctiva during the surgery. Yes. So the best thing to do is the least invasive. The ordinary cyclodestructive procedures induce inflammation even. The micropulse is cyclodestructive, but it is very gentle cyclodestruction. It doesn't cause such inflammation. And I think in such case, it induced a very good result, as Dr. Nader just told us.
Yes. Yeah. Thank you for this interesting case.
Thank you.
We will go for Dr. Mahmoud Hassan's case now.
Excuse me, Dr. Mustafa.
Yes, Dr.
I have very interesting questions for Dr. Nader, and I guess all the audience might benefit from the answers. We have a question from Dr. Magdi Afifi. What about systemic and topical plasminogen in your case, Dr. Nader? And what about recurrence of the membranes? I think you already talked about the recurrence of membranes. But what about systemic and topical plasminogen? And also we have 2 remaining questions. Please answer the first question for Dr. Magdi.
Well, some others try also the fresh frozen plasma, and it worked in many papers. We do not have or we do not prepare that plasminogen here in Egypt, and many patients are not aware of this as it's extremely rare. In 8 years, we have just seen only 4 or 5 cases. I do agree that we can use the plasminogen and also the fresh frozen plasma. It works well, and there are many papers about talking about that. Yes, I do
Okay,
agree.
we have another question from Dr. Suzanne Abdel Karim. What about amniotic membrane you use? You use fresh or dry commercially available amniotic membrane, Dr. Nader?
Well, this is an excellent or a perfect question. In the first two cases, we used the fresh amniotic membrane, but in this case, we used the dry, and we thought that it will not work as the fresh amniotic is better, but it worked. So if it's not available at your center, you can use the dry amniotic and it will work. We need also to share the experience of all audiences. We know that it's an autosomal recessive condition, so it may be in areas with positive consanguinity in our region. So we'll be very happy at Mike to share the experience of these doctors as the plasminogen, and I want to know the results of the plasminogen if you use it, doctor, and this will be
So you
perfect.
have a similar comment from Dr. Amal Al-Hamidan. She shared her opinion about it. The fresh frozen plasma is recommended and is more effective than heparin eye drops. Thanks,
Yes,
Dr.
yes.
Nader, for the very
Thank
interesting
you. Thank you so
presentation.
much. Thank you.
Okay, Dr. Mahmoud,
Good evening.
are you ready?
Yes.
Dr. Mahmoud is a glaucoma fellow at the Memorial Institute of Ophthalmic Research. He is a member of Royal College of Surgeons, Edinburgh. He is a fellow of International Council of Ophthalmology. He has his master's degree from Al Manufaya University, and he is interested in the surgical management of adult and pediatric glaucoma. Let's go straight for your interesting case.
Okay, I will start sharing my screen. Okay. Good evening, dear professors and doctors. Today I will discuss a case of Sturge-Weber syndrome associated with glaucoma. I'm Dr. Mahmoud Hassan, glaucoma fellow at Mike. This child came to us. He was 1 year old. He came to our pediatric clinic 3 years ago. He was suffering from photophobia and lacrimation. While we examine and inspect this child, we found that there was a port wine stain in his midline of his face, localized more in his right eyelid. Right eyeball was bigger in size. We took a history from his mother. Past medical history, there was convulsion since 2 months, weakness in his left half of his body. He was in anti-convulsion therapy, and family history was relevant pupil with no RAPD. We did examination under general anesthesia. Right eye revealed cloudy cornea, deep AC with Hebsch striatum. Horizontal corneal diameter, right eye was 11.5 and 12.5 vertical and horizontal millimeter, and intraocular pressure, right eye was 28 millimeter mercury, left eye was 14 millimeter mercury. This is a picture of his Hebsch striatum under microscope. Left eye was totally normal. While we do fundus examination of this child, his right eye was there was cupping. CG ratio was about 0.5, and left eye was normal. CG ratio was about 0.2. There was no evidence of choroidal hemangioma. His mother has his CT and MRI. CT scan show bigger size of his right eyeball with calcification of right hemicortex. MRI brain show atrophy of right hemicortex. This is a poll question. What should we do to this child? Give him topical eye drops, do combined trabeculotomy, combined trabeculotomy with mitomycin C, filtration surgery and drainage implant, non-penetrating surgery, or cyclodestructive procedure. This is a full discussion.
It's a very interesting case, Dr. Mahmoud.
Okay.
Dr. Ahmed, what about the medical treatment in such cases?
Well, sometimes medical treatment are recommended and give good results in such cases, because you know the surgery in such cases may have high risk. But sometimes we have to. We are obliged to do the surgery if there is like advanced cupping or uncontrollable pressure.
Yes.
Yeah.
Thank you, Karim. Okay, most of our attendees choose the trabeculectomy plus trabeculotomy plus mitomycin C, but it's obvious that we have not a single answer. Okay.
Let's see what we have done. Decision in this case, we give the child topical Travenorm eye drops once daily. Then we prepare the child for combined trabeculotomy. This is a picture in the operation. The conjunctiva is pulled back, revealing dilated episcleral vessels due to increased episcleral venous pressure. A scleral flap is made, and this section identifies the Schlemm canal. 6O nylon suture is threaded into Schlemm canal for confirmation. Then one arm of the trabeculotome is inserted into Schlemm canal. Gentle twisting motion of the trabeculotome allows entry into AC and allow formation of direct drainage of aqueous into Schlemm canal. This is a picture post-operative 1 week, and intraocular pressure measured by Perkin was 16 millimeter mercury. The child come after 1 year. On examination, corneal diameter increased to 13 and 14, vertical and horizontal. Intraocular pressure was 18 millimeter mercury. We give the child latanoprost. After 1 week of giving him latanoprost, intraocular pressure decreased to 12 millimeter mercury.
Dr. Mahmoud.
Optic disc evaluation with CD ratio on the right eye. Yes. Okay, I'm here. Follow up after 1 year to pediatrician for management of his seizures and refer him to physiotherapist for hemiparesis. The child was followed up every 6 months. After 4 years, corneal diameter was the same. IOP was 14 millimeter mercury. Best corrective visual acuity was 6/18 and 6/6. Now we will discuss a little bit about Sturge-Weber syndrome. It is one of the phacomatoses. It is hamartomatous hemangioma affecting the face, eyelid, which increase the risk of glaucoma and choroid. Pathophysiology of the glaucoma resistant to aqueous outflow due to elevated episcleral pressure plus or minus angle anomaly. Glaucoma to 70% of the cases. Sturge-Weber syndrome is characterized Sturge-Weber syndrome is characterized by classical triad, Port-Weinstein of his face, leptomeningeal capillary venous malformation, and ocular abnormalities. There is Roche scale used for classification of the Sturge-Weber syndrome. Both facial and leptomeningeal angioma may have glaucoma. It is type 1. Type 2 facial angioma alone have glaucoma. Type 3 isolated leptoglaucoma. Challenges in management of glaucoma associated with Sturge-Weber. It is very difficult than normal congenital glaucoma. If topical medication doesn't produce adequate response, glaucoma filtration surgery is the procedure of choice. Trabeculotomy with complication like choroidal effusion and suprachoroidal hemorrhage. There is a study done by Awad and his colleagues about using medical treatment in Sturge-Weber syndrome and glaucoma cases, and it is used in early stages in glaucoma as a temporary maneuver till you doing surgical procedure. And there is another German study done in 2012 about using medical treatment in glaucoma cases associated with Sturge-Weber syndrome. Devendra Sood recommended combined trabeculotomy. This is a study done in 2018 about long-term intraocular pressure after combined trabeculotomy in glaucoma associated with Sturge-Weber syndrome. which concluded that combined trabeculotomy showing promising result as treatment of Sturge-Weber syndrome associated glaucoma, which support our management in this case. Budens and his colleague and Jaya Kosak study support the usage of glaucoma drainage implant. This is old study about two-stage braided field glaucoma implant for childhood glaucoma with Sturge-Weber syndrome, which clarify effectiveness of using this glaucoma drainage device in two stages that decrease the risk of post-operative hypotony. And this is another study done in 2018 about Ahmed valve in childhood glaucoma with Sturge-Weber syndrome, and it supports usage of glaucoma device, the filtration device in these cases. There are other techniques just like non-penetrating glaucoma surgery, and it has the privilege of reducing and cyclodestructive procedures. Any pressure with hyperosmotic agent, placement of posterior sclerotomy prior to entering the eye, pre-placement of flap sutures or additional tight sutures during trabeculotomy, use of valved or two-stage glaucoma drainage device as a study before, reduce therapy of choroidal hemangioma prior to intraocular surgery. This is a study done in 2003 about doing posterior sclerotomy in cases of glaucoma with Sturge-Weber, and it showed great benefit of doing posterior sclerotomy to avoid complication like suprachoroidal hemorrhage or choroidal effusion. Seizures is a common feature in the first year of life due to hypoxia and ischemia of gluteus and cortex. Mental retardation always associated with style is multidisciplinary approach to involve pediatrician, ophthalmologist, physiotherapist, and psychiatrist, and increase with sport when stints.
Thank you, Dr. Mahmoud, for your interesting case. It's not an easy case of glaucoma. So I would like to ask you about risk factors of intraoperative complications in such cases.
Hemorrhage and there are.
Dr. Mahmoud, I think you have
there is another complication procedure which can you hear me now?
Now, yes, now you
okay. Another complication due to sudden decompression during or after the filtration procedure, it may lead to choroidal choroidal effusion. That's why we do
from our attendees use the mitomycin in this case.
Yeah.
Okay.
Actually, I will go for deep sclerectomy, which is much more safer for me. But as you know, deep sclerectomy needs a learning curve. So it needs someone very expert to go to do it. Otherwise, you may perforate the choroid or cause bleeding, or need someone very, as a learning curve, needs someone expert to do a deep sclerectomy in such case.
So in such cases, in such cases, you prefer to do deep sclerectomy combined with the trabeculectomy.
With the trabeculotomy,
trabeculotomy, with the trabeculotomy.
And mitomycin also.
Okay, so you believe in such cases we need to combine both procedures?
Yes.
The angle surgery and the filtration surgery?
Yes.
Okay. We have a question from Sarah Khan. Why trabeculectomy if episcleral pressure is high? She's asking.
Well, if sclera is high,
Well,
we need to
I-
lower
He's
to
asking about trabeculotomy. Dr. Mustafa, why
Trabeculotomy, yes.
trabeculotomy?
Why trabeculotomy if episcleral pressure is high? She wants to know why you added trabeculotomy to that trabeculectomy.
we are trying to have all what we can do in one session for such a child. We don't want to put him in another surgery. So trabeculotomy, actually, it is the primary procedure for most of the congenital cases, even for the secondary glaucomas, primary or secondary glaucomas. So we combine it as routine. Yeah,
Okay.
and the results are good. I had the presentation last week. You know, such simple same case. I did deep sclerectomy with trabeculotomy, and we
Same
had
case
good
with
result. Yeah,
Sturge
another
Weber.
case, not this.
Another
case.
case of Sturge Weber syndrome.
Yeah.
What about other phacomatoses? Do you have the same experience with glaucoma secondary?
I don't have such an experience, and I didn't see a lot of other phacomatoses. I have seen 2 or 3 cases of Sturge Weber.
Yes.
I didn't meet other phacomatoses actually, but mostly it will be the same. We'll do the same procedure, regarding that the angle is not infiltrated by a nevus or by a neurofibroma or what or something like that.
Okay, the pediatric glaucoma was very interesting. Thank you, Dr. Ahmed. Thank you, Nader. Thank you, Mahmoud. And now we will proceed to the strabismus section. Karim.
Hello, doctor. Greetings from Orchidia Pharmaceutical Company. I hope you, your family, and all your beloved ones are safe and in good health. Today, I'm going to talk about glaucoma patients. Twinzol brings patients to the targeted IOP regardless of their baseline. Twinzol reduces the IOP by 30% for patients whom IOP is more than 25 millimeter mercury. And for those whom IOP is more than 30 millimeter mercury, Twinzol could reduce it up to 50% of the IOP. Another product for your glaucoma patients is Alphanova. Alphanova is the perfect add-on therapy with a superior neuroprotective effect, along with less incidence of ocular allergy as Alphanova is preserved with sodium purite. Finally, I would like to remind you with OcuGuard, a tailored formula of vitamins, minerals, and herbs. Thank you for your time.
Thank you, Orchidia. And now, let's go for the strabismus surgery with Dr. Magid. Dr. Magid, good evening.
Welcome, Dr. Mustafa.
Dr. Magid is an upcoming star, I believe. He's a fellow of pediatric ophthalmology and strabismus at Mike. He had his master's in ophthalmology and the Egyptian Fellowship of Ophthalmology. He is very interested in dealing with the children and in strabismus. Okay, Dr. Magid, let's go for your interesting case.
Can I share my screen?
Yes, you can, please.
Good evening, dear doctors and colleagues. My presentation today is one surgery is sometimes is not enough. It's a case presentation of 14 years old male child presented with ocular deviation of the right eye 8 months ago. History showing ocular deviation following head trauma 8 months ago, and there is no previous ocular surgery and there is no fever. Ocular examination showing anterior segment is free, the pupil is rounded, regular, reactive, and the fundus examination was normal. Visual acuity showing 618 OD and 6x OS, and the current refraction is irrelevant. The photo of the patient showing right esotropy and the primary position 65 prism diopter, increasing in the right gaze up to 100 prism diopter with marked limitation of the epiduction of the right eye in the right gaze, not crossing the middle line, and decreasing up to 45 prism diopter in the left gaze, which is normal. Cover test and ocular motility showing marked limitation of the epiduction of the right eye up to -4, this is not crossing the middle line. The patient having right esotropy and the primary position 65 prism diopter, and there is no epiduction saccade of the right eye in the right gaze. no other cranial nerve affection, and there is no gaze palsy. Neuroimaging was done, which is normal. So the first pool discussion, what's your diagnosis? Right 6 nerve palsy, right medial wall fracture, decompensating ET, or right Duane syndrome.
Dr. Magid, would you please bring back the photos of the motility so
Okay.
our attendees can judge well? Yes, the patient has ET in the
patient
primary
has
position.
okay, right esotropia, 65 prism diopter in the primary position, increasing in the right gaze up to 100 prism diopter, and decreasing in the left gaze up to 45 prism diopter.
Thank you, Karim.
So the pool discussion, we have 4 questions: right 6 nerve palsy, right medial wall fracture, decompensating ED, or right Duane. Okay.
Almost all.
65% having
Most
right
of
6
them,
nerve
yes.
palsy.
Yes.
And this is a diagnosis, okay. The
Yes.
patient having right 6 nerve palsy, yes, the patient, because the patient having ocular deviation 8 months ago with marked limitation of the epiduction in the right gaze up to -4, but there is no epiduction saccade and associated with widening of the palpebral fissure in the right gaze, indicating this is right 6 nerve palsy. Right medial wall fracture is a very rare possibility. When we are having medial wall fracture with trapping of the medial rectus muscle, also we are having esotropia in the primary position with marked limitation of the epiduction, but with narrowing of the palpebral fissure. Decompensating ET, usually it's a commitant strabismus, but my case is incomitant. Right Duane retraction syndrome, usually dating since birth, is associated with narrowing of the palpebral fissure, not widening of the palpebral fissure. So it's a case of right traumatic 6 nerve palsy. Another pool discussion, your management. Karim. Either right medial rectus recession with split tendon transfer Hümelsheim in the same setting, medial rectus recession with full tendon transfer Napo residual, botulinum toxin of the medial rectus with split tendon transfer Hümelsheim, bilateral medial rectus recession with more recession with a sound eye.
It's a very interesting case.
Thank you, Dr. Mustafa.
Dr. Haiba, what's your favorite approach in such cases?
You are asking me, Dr. Mustafa?
I'm asking Dr. Haiba. Thank you, Dr. May.
Okay, okay.
أنا for my case, يعني for my opinion, I prefer first to tackle the pathology. In those cases, a case of 6 nerve palsy, after 1 year, it is supposed for the patient to have a very tight medial rectus. So the first thing I do in those cases, I usually make the force reduction test and check whether the medial rectus is tight or not, and then make recession of the medial rectus first, and then make to do half tendon transposition of the Hümelsheim, the split tendon, and I add lateral rectus tucking as the first intervention. I do all these steps in the first intervention because I believe in the that some fibers might be acting in the non-functioning muscle during the clinical examination, while the muscle might have some acting fibers and add to my treatment and be stable for a long time. And so in those cases, I do this first. I never do transposition without adding medial rectus recession in the same setting in the first intervention.
Yes.
Let's see what Dr. Magid did for the case and what was his results.
Okay.
Okay. The first choice, yes, is my preferred choice. As this patient having ocular deviation 8 months ago and with marked limitation of the abduction in the right gaze up to -4, having very poor lateral rectus function, so the patient will have a great benefit from the vertical recti muscle transposition. But vertical recti transposition alone will not have a good effect, so we are adding medial rectus recession with it. So what are we going to do? My plan First, force reduction test, which is negative, confirming that is right 6 nerve palsy. And we are going to do large medial rectus recession with Himmelsheim procedure in the right eye with some modification for more improvement of epiduction. Himmelsheim procedure, we are splitting both superior rectus and inferior rectus muscle into two halves, splitting up to 14 millimeter posterior to allow free mobility of both halves before suturing it on either side of the lateral rectus muscle according to the spiral of thorax. We added prox resection, resecting 5 millimeter of the lateral half of superior rectus muscle and the inferior rectus muscle before suturing it to the lateral rectus muscle. We added also right modification, about 5 millimeter, suturing the lateral halves of both inferior and superior recti muscle to the lateral rectus about 5 millimeter from the lateral rectus insertion. Today, post-operative, the patient is orthotropic in the primary position. There is improvement of epiduction. Now it's crossing the middle line, which is good. But the patient coming 6 months post-operative with recurrent esotropia again, about 20 Bresson diopter. That's primary position, esotropic in the primary position, normal left gaze, limited epiduction of the right gaze, but crossing the middle line. So another pool management, Karim. Either medial rectus recession of the contralateral eye, re-recession of the ipsilateral medial rectus muscle, or large resection of ipsilateral paralyzed lateral rectus muscle. But, okay.
Dr. Zainab,
Yes.
are you with us?
Yes, with you. Resection of ipsilateral paralyzed lateral rectus muscle. I've done it twice, and actually, it with me it was of no value. So I didn't try it again. While re-recession, medial rectus recession of the contralateral eye, I think this is the best.
Re-recession of the contralateral eye.
Yes. لا recession medial rectus recession of the contralateral eye, it's
Medial rectus
de novo.
Yeah. Yes. Okay.
So I have a comment on the case, Dr. Magid. I didn't notice whether you did a medial rectus recession immediately in the same session or not. I didn't notice.
In the same set.
I did medial rectus recession with Himmelsheim procedure in the same setting, about 7 millimeter.
Okay. And you did not do any lateral rectus resection?
No. Just medial rectus recession with Himmelsheim procedure.
So if you're not convinced about talking of the dead muscle that seems to be dead in your clinical examination, you need to do the active generation test before deciding to do tucking or not. You cannot judge the muscle is not working by just the clinical examination. You need to do the active generation test to detect whether the muscle has some remaining activity or not. And so in this case, if you add the lateral rectus tucking, even if you're afraid of the anterior segment ischemia, you might have a tucking which is very preserving to the vascular supply of the anterior segment of the eye. And so you can add the tucking of the lateral rectus anyhow, because what it would hurt, well, nothing. You have nothing to lose if you add a lateral rectus tucking in your case.
Okay. But the patient having good visual acuity in such eye, if you are acting on 3 muscles, if you are acting on more than 3 muscles in one eye, there is a high risk of anterior segment ischemia. So we are afraid from doing resection of the lateral rectus muscle with other 2 muscles.
I just said
you tucking.
Lateral rectus tucking, which is vessel preserving.
It's a good choice. It's a good choice, but we don't do it.
Dr. Hiwa, do you think it is beneficial in your cases? Do you think it was beneficial to do resection or tuck to a dead muscle?
I don't know if I'm right or wrong, but I have a case series with tucking of a dead muscle which never let me down. I do tucking of the dead muscle in all my cases, and I have very good results and stable results over time. I believe to decide not to touch this muscle, I need to make the active generation test. Many patients are incooperative, not much cooperative to do the active generation test. Sometimes you have results and sometimes you're not sure. And so I try to make it as a routine in all my cases. And so I found it is very reproducible for me and predictable in all my cases. And my policy in all the cranial nerve pulses cases is that I never go to the contralateral eye without getting the best out the paralyzed eye. So I do everything and I use everything, every little thing in the paralyzed eye first, and then switch to the other eye.
Okay.
And
So,
another thing, you have a very large angle, 65%.
yes, 65%.
And so,
65%.
and so it's not expected to have good results of just only having or doing the medial rectus recession and the split tendon Himmelshine in the ipsilateral eye.
So we are having some modifications like resection, Brooks resection, and right modification to increasing its effect and more improvement of epiduction.
The medial rectus recession, the ordinary medial rectus recession would correct only 20 present diopters maximum, and if you make a strengthening force against the recessed muscle, you might have more and more results, almost 30 present diopters of correction. And they have split tendon have a Himmelshine in the reviews. It would never correct more than 20 present diopters, whatever you did. And so I guess it's not enough from the first, from my expectation, it's not enough for me. And so I add the tucking of the dead muscle, even to have just a boost of 10 present diopters only. And so I have a good results from the first session.
Okay.
Dr. Heba, I did it. It was like a leash effect. I did it, yes, twice. It's not much, but it was as if leash effect for about 1 month. It was temporary. And then it, again, recur again. So I didn't, but as you have said, it is not harmful.
You would lose nothing if you tried this. Yes. And then post your management in the next setting with contralateral eye. Another thing and another opinion, which is very convincing actually, is that if you doing the contralateral medial rectus, what do you expect? You expect that the hearing globe, the muscles would go more, the impulses go more and more to the recessed medial rectus, and so as going to the paralyzed contralateral lateral rectus. Do you believe that the impulses, just those impulses, can just boost a dead muscle? If you believe this is a dead muscle, this muscle is dead, do you believe that the hearing slow would correct and would give and would wake this muscle up? Never. You need to boost this muscle, so when you do the contralateral medial rectus session, the hearing globe would be more beneficial and more reproducible in your future stability of the angle even. I know many patients that are not, many doctors are not convinced with this principle, but I have many cases, and I would do a case series to publish a case series of all my cases. I already presented all the cases, a larger group of cases in many conferences. I think in the last couple of years, but I would better publish a series of cases for everyone to know that it might be beneficial in your management.
Okay, agreed, Dr.
So,
Okay.
Dr. Heba, you believe in strengthening a virtually dead muscle, but the pull is coming with medial rectus recession of the contralateral eye. Almost 50% of the attendees choose the medial rectus recession.
So, you know, large resection of the lap ipsilateral paralyzed lateral rectus. It's satisfactory results for me, because I think 1 year ago nobody would talk about this. This might be helpful for him, and so I'm very satisfied with the 33% that I affected that opinion. All my lectures. Thank you.
Okay, Dr. Magid, please.
So, okay. So my preferred choice, medial rectus association of the contralateral eye-like audience, but the problem here, the mother of the patient is refusing to act on the sound eye. It's a very big problem. So what we're going to do, our plan, large re-recession of the ipsilateral medial rectus muscle. 2 weeks post-operative, the patient is orthotropic in the primary position with normal left gaze, normal up gaze, normal up and right gaze. And there is limitation of the abduction of the right eye, but crossing the middle line. So the patient is orthotropic post-operative, but because of large re-recession of the medial rectus muscle, we are having right limited deduction of the right eye. Pre-operative, the patient was isotropic 65 prism diopter, and after the second surgery, the patient is orthotropic now. Isotropic and the patient orthotropic now, and he is still orthotropic until now. Review of literature showing Hurl's pediatric ophthalmology showing in eye with totally paralyzed lateral rectus muscle and esotropia in the range of 55 prism diopter, the medial rectus should be recessed approximately 12 millimeter. Anything less than this amount will result in an eye will become more isotropic with time. Any more than 12 millimeter will cause substantial limitation of deduction. Resecting the lateral rectus muscle may not give much additional benefit if totally paralyzed. Other review of literature showing outcome of 3 different vertical rectus muscle transposition procedures for complete inducing nerve palsy. Either full tendon transposition, full tendon transposition with 4 millimeter resection, full tendon transposition with Mybex sutures. We have found full tendon transposition with resection corrected the most esotropia and improved impeduction to the greatest degree. Another review of literature showing augmented Himmelshine procedure to treat complete abduced nerve palsy, showing vertical recti transposition with Foster modification can create a binocular diplopia free field of 40 to 70 degrees in patient with 6 nerve palsy. Other review of literature showing outcomes after superior rectus transposition and vertical and medial rectus cessation versus vertical recti transposition for 6 nerve palsy, showing superior rectus transposition plus medial rectus cessation, showing equal reduction in esotropia but greater improvement in abduction rather than vertical recti transposition alone with less need for future intervention. So the take-home message, multiple surgeries in paralytic strabismus may be required. Association of Himmelshine procedure with Bruch's resection and right modification gives better results than Himmelshine alone. Reoperating on the medial rectus muscle may put the muscle back further from the limbus than it's recommended in standard strabismus surgery. Split tendon transfer with some modification is more preferred than full tendon transfer with less risk of anterior segment ischemia, especially if we are acting on 3 muscles or more. Thank you.
Question. I have question for Dr. Megid. When you re-enter on the medial rectus, this medial rectus muscle, did you find that it was tight in the force reduction test?
No, force reduction was negative, indicating this is complete paralysis of the lateral rectus muscle with no contracture of the medial rectus muscle.
Actually, medial rectus muscle is a very sensitive muscle. We count even every half millimeters when we do in any case of esotropia. And so in this case, it's for me, it's unpredictable even to find this results without having a limited adduction of this patient. You need to counsel the patient before your surgery that he might have limited adduction in his opposite gaze, in his left gaze, when you do this large and huge amount of the medial rectus recession. Because you are putting the muscle far behind the equator, and you are weakening the muscle, the torque of the muscle, you are polishing the torque of the muscle. I think the muscle would act on if it was put on the 12 millimeters, if it was very, very tight, and otherwise, if it's the force reduction it was negative, I think the patient would have definitely limited adduction. And I'd like to check, you bring back the photos of the patient to check the adduction. If you if you did not have any limited adduction, you're lucky. In this case, yeah, you're so lucky. In this case, if you did not have any limited adduction.
Dr. I think Dr. Megid said that he has the patient had the -1 limited adduction.
The patient post-operative have a limited deduction, right? -1.
How many, the photos of the patients you took already those photos. How long after the surgery?
2 months.
1 month after surgery.
Sorry,
1 and 2 months after surgery, up to 2 months.
after surgery. And when did you do this case?
Okay, yeah, the first surgery was about 6 months. Then the patient coming again after 6 months. We are doing the second surgery and we are following it until 2 months after surgery.
Okay.
Second surgery.
Okay, I think this patient needs a very strict follow-up because you might find a limited adduction over time increasing. And I'd like to listen to Dr. Zainab's opinion about the case. What is your opinion, Dr. Zainab?
This patient, his job is a mechanic, and the first head trauma was from a motor car accident falling on his head, and he can't read. So I told him that it will be a convergence problem after the surgery, and he was so happy, agreed very much that he will do it. So we have counseled the patient.
You have counseled the patient about this, yes, okay. And what is your preferred technique for transposition? Only the Hamilton, or you try other techniques, the Janssen, the other techniques in the transposition? What is your opinion?
After I've heard the webinar of Dr. Linda, I will try superior rectus muscle only.
Superior rectus muscle only. Okay, great. We have already two studies are done right now on evaluating the superior rectus transposition for the limited abduction, or one of them for MD thesis, the MD thesis of Dr. Mustafa Azab, and the other in our research center to evaluate this this technique. I do believe in the superior rectus transposition only. And interestingly, some surgeons, like Dr. Akmal Rizk, he believes in inferior rectus recession transposition only. Thank you, Dr. Megan, for your nice case, and I hope you have this excellent result in all your upcoming cases. Thank you.
Thank you. Thank you, Dr. Heba. Thank you, Dr. Zainab.
We have some questions from the attendees. The first question from Dr. Al-Kashif. Dr. Zainab, when can we do the operation in cases of post-traumatic sixth nerve palsy? Timing of intervening.
6 months post-operative.
6 months post-operative. Okay, Dr. Fay Al-Mahmoudi is asking, he says resection of dead muscle doesn't work in our experience. I think this question is for you, Dr. Heba. I know you answered this question.
I answered already.
Yes.
He asked the question before I answered. I just answered. It is my own experience, and I'd like to emphasize that it is to boost your management, to aid your management. It's not the main strategy. It's not your main strategy. It is just as a helping muscle before you tackle the other eye. It's my strategy in many cases, and even in the third nerve palsy, you might watch our previous webinar, the operation on strabismus. Thanks, Dr. Fay, for your question.
Thank you, Dr. Heba. Dr. Magid, Dr. Kashif is asking about the risk of anterior segment ischemia after operating on 3 muscles on the same session.
In this case, we are going to do, we have done medial rectus incision with half tendon transposition of superior and inferior rectus muscle, preserving half of the anterior ciliary vessels with less risk of anterior segment ischemia. If we are going to do medial rectus incision with full tendon transposition of superior rectus and inferior rectus muscle, violating major contributor to anterior segment circulation, this increases the risk of anterior segment ischemia. So my it's better to not acting on 3 muscles or more in the same setting to avoid the risk of anterior segment ischemia, which is very difficult and irreversible.
The last question from our great mentor, Dr. Ayman Al-Ghunaimi. He asks you, Dr. Magid, if you did performed an active force generation test for this patient before operating, before the first surgery. Have you done it?
Actually, no. We are doing a force reduction test, which is negative. indicating that is a complete paralysis of the lateral rectus muscle, and there is no restriction, no contraction of the medial rectus muscle.
Dr. Heba, you said a very good tip about performing the active force generation test, so we can evaluate the strength of the lateral rectus. Thank you, Dr. Heba. Thank you so much.
Me and Dr. Ayman are friends, and so we have the same moment. Know that a long time ago. We have this every time.
Okay, Dr. Salah, are you ready? Dr. Magid, if you please stop sharing. Yes,
Okay.
thank you. And now to Dr. Sarah, مسك الختام. Dr. Salah is a great fellow of pediatric ophthalmology and strabismus in our beloved Mike. He had his master's from Qasr Al Aini, and his area of interest is strabismus. Dr. Salah, please share your screen.
Okay. Thank you, Dr. Mustafa. Let's start.
Yes.
Good evening. Good evening, dear doctors and colleagues. Today my topic is about congenital nystagmus, not always benign. Let's start with the first case. 4 years old female child presented with repetitive oscillation of the eye. The chief complaint observed by the parent was abnormal head posture. As we see in this photo, there is left face turn. History of the present illness. The condition started at the age of 2 months old with no photophobia, fever, head nodding, or ocular trauma, no drug administration, irrelevant perinatal and family history. Ocular examination in such case is very important. We should do good ocular examination to exclude any anomaly. Visual acuity was 6/9 in both eyes with this cycloplegic refraction. Anterior segment examination was free, rounded, regular, reactive pupil. Dilated fundus examination was normal. There is left face turn and free ocular motility. This is the video for our patient. We have conjugate, horizontal, uniplanar, jerky nystagmus. Its direction is to the right with null point. It has moderate frequency and fine amplitude, increase with fixation on far target and decrease with convergence. So what is the null point? We have in our case null point, and its direction was to the right as we said before. The null point is the field of the gaze in which nystagmus intensity is minimal, so that there is the best visual acuity. As a conclusion, we have a case of congenital nystagmus with left face turn. So what should we do? And this is a poll for our audience. Refer to neurosurgeon, give gabapentin, put a prism to correct the abnormal head posture, Kistin boom procedure, neuroimaging, or recessing all four thigh muscle. We are waiting for you.
Dr. Zainab, have you ever did the recession of all four recti muscles?
Unfortunately, no.
Dr. Heba,
Unfortunately, no.
Dr. Heba, have you such experience in doing that?
I don't have such experience, and I do not find it is beneficial nowadays with the era, because these days we have the era of Azopt. Azopt eye drops are very beneficial in reducing the amplitude and frequency of the nystagmus in most of the patients. We already enrolled a study in our research center to evaluate the effect of Azopt with the doctor. I have Dr. Sharif Kamel in the study, in this research, with me to evaluate the effect of the Azopt on all the pediatric cases the effect on reducing the amplitude and the frequency and even improving the visual acuity in some cases, whether the pediatric or in the adult cases. In this era, I don't find the recession of the four muscles is beneficial. This technique is beneficial anymore. I mean, so I don't have the experience in recessing all the four recti muscles in the nystagmus cases. And to the point, it is not, this technique cannot be done in any patient with abnormal head posture, with null point to the right or to the left. This is not just it. This question is not, this is not the right place for this question or this technique. In the literature, they are doing the recession of all recti, the four muscles, when the patient has no abnormal head posture and has nystagmus. And it's not the question, just he just playing with the audience to choose, to know what to choose.
Okay, Karim, bring up the results, please. Neuroimaging. Oh, 50%.
Most of our audience go to neuroimaging.
Yes.
Let we retard the discussion of this answer to the second case. When to choose neuroimaging and when to choose the other answers. In our case, we do a custom boom procedure, which is really described for nystagmus with related head posture. Its idea is shifting the two eye to the primary position by the same amount. As we see in this figure, the two eye is to the right, recession resection in both eyes, the two eyes is shifted to the primary position. In our case, we do lateral rectus recession 10 millimeter and the medial rectus resection 8.5 millimeter in the right eye, and medial rectus recession 7 millimeter, lateral rectus resection 11 millimeter in the left eye. The eyes are in right gaze and we want to move it to the left, as we see here. This is 2-day post-operative photo, 1 month post-operative photo, 3 months post-operative photo, lastly 6 months post-operative photo. As we see, there is no abnormal head posture as it disappears after the procedure. Let's go to the more case, which is more interesting. 8-month-old child presented with dancing eye. Chief complaint observed by the patient was abnormal head posture and dancing head. This is the photo of our child. There is left face turn and right head tilt, as we see in this photo. History of the present illness. Condition started at age of 6 months with no fever or photophobia, trauma, drug administration, but there is head nodding, which we should put in mind. Our family and the perinatal history was irrelevant also. We said before that ocular examination in a case of nystagmus is very important, as any abnormalities in visual pathway or anterior segment which may affect vision can cause nystagmus. Visual acuity in such child can't be detected. He can fix and follow. This is his cycloplegic refraction. Free ocular motility, there is head nodding. Anterior segment was free, rounded, regular, reactive pupil, but we have a mild optic disc pallor in both eyes on dilated fundus examination, and we should put this in mind. This is the video of our patient. We can see the head nodding, also the nystagmus. Which is conjugate, horizontal, uniplanar, jerky nystagmus. There was a null point, increase on fixation, and decrease on convergence. Let's have a look again on the video. This is the null point. So, is it a congenital nystagmus? We can say that it is a congenital nystagmus at it decrease with convergence, increase with fixation. There is left face term, and it's a jerky nystagmus with null point. So, what about head nodding and head tilt? What should we do? As the previous case, we have the same questions. What about our audience answer? Let's go to the second rule.
So, Dr. Salah, in the first case, we didn't have head nodding,
Yes,
and in this case, we have head nodding.
we have head nodding in this case, and we have abnormal fundus examination in the form of pale optic disc.
Yes.
The other finding is the same about head tilt and the description of the nystagmus.
I think this is a turning point, finding a pale
Yes.
optic disc and also the head nodding.
Yes.
Okay, Karim, thank you. Dr. Salah.
Okay. We have the correct answer. Yani, most of our audience choose also neuroimaging. So that yani, we will answer when to use a neuroimaging and when to use another answer. Okay. We do a neuroimaging. It is a case of atypical nystagmus. As we said before with Dr. Mustafa, we have head nodding and we have abnormal fundus examination of the form of optic disc pallor. Neuroimaging was done, which relieve a huge mass at the splenium of corpus callosum at this, at the arrow, about 5 millimeter in horizontal and vertical dimension. A huge brain tumor. Is it a case of spasmus niutanis? Usually spasmus niutanis is a pendular nystagmus, but our case is a jerky nystagmus. So it is a spasmus niutanis like nystagmus, which is often associated with underlying ocular, intracranial, or systemic abnormalities. First cases reported by Kelly was a case of optic glioma presented with spasmus niutanis like symptoms. This study indicates that eye and head movement indicating that eye and head movement recording don't allow differentiation between benign spasmus niutanis and spasmus niutanis like disease. The differentiation must be made on the basis of neuroimaging, so that neuroimaging is a must in this case. So what is the warning sign? Which should I put in mind? Number one, optic nerve dysfunction in the form of relative afferent pupillary defect, optic atrophy, optic disc pallor. Number two, associated atypical nystagmus. If there is upbeat nystagmus, which usually occur with posterior fossa lesion, or downbeat nystagmus, which may occur with Arnold-Chiari malformation, monocular nystagmus, gaze-evoked nystagmus, convergence retraction nystagmus, which occur with dorsal midbrain syndrome, or acquired nystagmus. This is the warning sign which we should put in mind. So take home message. It is mandatory to do neuroimaging in all cases of spasmus niutanis, as usually it may be benign, but sometimes, as we see, it may be associated with anterior visual pathway gliomas, or it may be spasmus niutanis-like syndrome with associated intracranial or intraocular abnormalities or tumor. The presence of optic nerve dysfunction or atypical nystagmus like should arouse suspicion. Good history and ocular examination, as we said before, is a must to differentiate the benign congenital nystagmus from the dangerous acquired nystagmus. Thank you.
Thank you, Dr. Salah. It's a great case, and it's very nice from you to put two different cases in the same and different approaches.
Yes.
Dr. Hisham Shaheen is asking you how do you calculate the amount of recession and resection for such cases of nystagmus? I think he's asking about the custom bone procedure. Yes.
Custom bone procedure, there is a table right in many boxes which is fixed, and our professors before that say we can't change the amount of recession and resection. We measure the angle of abnormal head posture in the form of face turn, and there is a table which detect each angle, what to do, resect, how much. It's written in the table. And before that, Dr. Ayman and Dr. Zainab say he can't change the number of recession resection detected in the table. In some cases of XT or ET, we and our professors can change out of the table some degree, but in custom bone procedure, I think all of them do what the table describe. لأن الidea that is to shift the two eyes to the primary position by the same amount, so that we do what is written in the table after measuring the angle of face tilt.
Dr. Heba, Dr. I need to know your experience with the Azopt. I saw many cases with you with the congenital nystagmus, and you always advise with the Azopt. What's your experience?
Very nice cases that the vision improves with Azopt, and even the mother and father reported that the amplitude and frequency of the nystagmus decreased obviously. In the case, I have even cases with apologed nystagmus. In case I have a couple of cases with apologed nystagmus. The Azopt is very, very helpful in all cases of the nystagmus. I'm not talking about the abnormal head portion. I'm talking about the nystagmus. And this is my experience, and you can find this results in many researches, and you find it widely described in the literature. I'm talking about our study because we want to make our figures and our own results in our research center in the Memorial Institute. Before going ahead and say my opinion in Dr. Salah case, I'd like to thank you, Dr. Salah, because this case is the fruit of the day, really, because if we came up with just a conclusion, or a take-home message, or stay-home message, as Nader always say, with this take-home message, it's very enough for me for this webinar. I'd like to thank first Dr. Zainab for supervising you and both cases, and I'd like to listen to her comment first before I say my comment. Please, Dr. Zainab, tell us your experience and your comment on both cases.
First, I would like to ask you, Dr. Heba, please, about the Azopt. In which cases do you administer them? You mean congenital, sensory,
any
spasmus nutans?
Any case of Azopt, not in spasmus nutans case. The pathology of spasmus nutans is different from the congenital nystagmus to give the Azopt. I give Azopt in all cases of nystagmus, whether in adult cases or pediatric age group, and even in all the cases with delayed visual maturation. It gives an excellent result in all those cases. It improves the visual function, it improves, it acts on the ganglion cell layer level, and it has a very, very marvelous and good results. I advise you all to try Azopt. And even in all cases with optic nerve dysfunction, the cases with hereditary optic nerve atrophy, or the patient with trauma or any optic nerve or severe retinal disease, even in severe retinal dystrophy, I give usually Azopt, as advised by our professor, Dr. Sharif Kamel. Long ago, I advised.
اللي فتح موبايل يقفله النت بتاعه.
Please mute yourself, Dr. Salah. Please
صلاح
mute.
mute yourself.
ماشي واحد شغال واحد بس.
And so I have a very good experience, and I advise you all, for the sake of the patients, to try Azopt with all of them, because it would never hurt as well to give the patient the Azopt. Even if I saw some neuro-ophthalmologists even shift to the they combined not only the brinzolamide, but also to combine with the beta blockers. And I just want to emphasize that the brinzolamide molecule is the only molecule that would give this result. I'm not talking about the dorzolamide. I'm talking about the brinzolamide. Again, I'd like to listen to your comments about the cases, Dr. Zina, before commenting on these cases. I think this case might raise a very, very hot discussion. When you ask for neuroimaging, Dr. Zainab, in your cases?
As Dr. Salah said, first of all, if it is multiplanar, if it is uniplanar, maybe I have some relief. But if it has multiplanar or upbeat, downbeat, I order neuroimaging. Also, the history with the onset is very important for me, because I have read about something called the Bruns nystagmus. It's like congenital nystagmus, straightforward, as Dr. Salah said. Although Bruns nystagmus, it has also horizontal, not always uniplanar, sometimes multiplanar, but it has, when looking to the side of the lesion of the pontine, cerebellopontine angle, it has a low frequency, high amplitude, while in the other gaze, it will be high frequency, low amplitude, as if the amplitude is much slow, or the intensity of the nystagmus is slower, as if it is null point, although it has a cerebellopontine angle tumor. So if we have a patient like Dr. Salah with null point and the posture, so it is for long time, so it is a straightforward. But history is a must. If this onset is acquired recently, with that type of Dr. Salah said, also horizontal and increasing gaze and decrease in the other gaze, as if null point, it may be cerebellopontine angle tumor also. It may need imaging also.
Okay, thanks, Dr. Zainab. I want to wrap it up. If I were in the place or in the shoes of all the audience, I would get in a great mess with when to order MRI or neuroimaging, and where not to order. We have sensitive cases and situations when you in the gray zone, you don't know whether to ask for a neuroimaging or not. In the first case, you had a congenital nystagmus. In the second case, you had a spasmus nutans. There is a difference between those entities, and there are many similarities. The onset is very important, but you did not say a very important point, because the congenital nystagmus usually had the onset before 6 months.
6 months, yes.
The spasmus nutans cases, or the spasmus nutans like syndrome, might have an onset after 6 months.
6 months.
So
yes.
it's a very, very important point for all the audience and the young generation to know. But sometimes in your office, you might have a vague history from the mother, and so you need other characters that you depend on to differentiate whether it is congenital or it is acquired. Of course, if you had an older child, you can ask him whether, can you see this the things shaking in front of you? Do you have oscillopsia? If he said yes, I have oscillopsia, you would acquired nystagmus. But what if you don't have, if you have a nonverbal, or even a child 6 months old, or even a child 10 months old, the mother does not know when the nystagmus starts. There is 10 characters of the congenital nystagmus that we depend to conclude this is a case of congenital nystagmus. It is horizontal, uniplanar, decreased with conversions, increased with fixation, and this type already has the abnormal head posture and the null point as well. But what about the cases with are very, very, very deceiving, the cases with the triad of head nodding, nystagmus, and the abnormal head posture? And this is the area of concern today. What if I have a case of the nystagmus, head nodding, and abnormal head posture? This triad has a wide differential diagnosis. It might be as simple as an infantile nystagmus syndrome, the ordinary and the very common infantile nystagmus syndrome. You might have a spasmus nutans-like cases, and you might have the benign spasmus nutans, and you might have the neurological spasmus nutans, which Dr. Salah just said. It is the patient had already optic atrophy. In this case, it is for me, it is not a spasmus nutans-like case. The spasmus nutans-like syndrome are the cases with spasmus nutans features, but with abnormal vision. In cases with retinal dystrophies, achromatopsia, and all those cases, those are the spasmus nutans-like syndrome cases. So we have 4 entities: the benign spasmus nutans, the neurological spasmus nutans with optic neurogliomas, the spasmus nutans-like syndromes, and the infantile nystagmus syndrome. The head nodding actually is not an associated pathology. It is not an associated pathology. It is a compensatory mechanism, because the patient might have dissociated nystagmus, the different nystagmus in the right eye and left eye in the amplitude, or even monocular nystagmus. And when he make this head nodding, he had his nystagmus slower in the frequency and more symmetric, and he can see better. And so this is a compensatory mechanism. You can find this compensatory mechanism with the infantile nystagmus syndrome. And so don't judge. I myself had just in my clinic yesterday a case with head nodding and congenital nystagmus, but the story started with just nystagmus, and then the patient after 6 months developed head nodding to and abnormal head posture to improve and maximize his vision. Another point, whether pendular or jerky, I know that the pendular nystagmus is more, the spasmus nutans is more to be pendular nystagmus, but the spasmus nutans-like syndromes in all the 100% of cases in the literature, it is found to be pendular in 100% of cases in many literature. And so it is not the differentiating strong point between the 2 entities. But I like to, and I love the take-home message of Dr. Salah, that in all cases of spasmus nutans, please ask for neuro imaging. Just look for the history, for the onset, whether before or after 6 months old. Please, if you are comfortable with the congenital nystagmus and you have all the characters, the abnormal head posture, do not be that much astonished and surprised with the nodding, because it is a maximizing, compensating mechanism to maximize the vision of the patient. Thank you so much, Dr. Salah, for the very interesting case and the fruit of the day. Thanks for you all, our fellows, even fellows of the pediatric ophthalmology and the strabismus, or even the pediatric glaucoma, all the fellows of the mic. Thanks, Dr. Mustafa. Thanks, Dr. Ahmed.
I just have one comment, Dr. Heba, about the question that one of the attendees asked about why trabeculotomy in Sturge Weber, although we have a high venous pressure, high episcleral pressure.
Yes.
In cases of Sturge Weber, we have 2 mechanisms of glaucoma. One of them is the increased episcleral venous pressure, which cause back pressure on the other mechanism is angle anomaly. Some of these cases have angle anomaly, so we are addressing the angle anomaly. Maybe we don't know exactly the mechanism in such case, maybe both mechanisms or one of them. So we are addressing both mechanisms. This is just to clarify my answer. Thank you for your.
Thanks, Dr. Dewidar, and I think it's time to take questions of the audience. Dr. Mustafa, please go ahead
Yes,
and
The azopt is on the top of the questions, Dr. Heba. All our attendees is attracted to the azopt. They asking about the dose and the age.
So, in all cases before 6 months of age, I just give it once or twice maximum. In the first year of life, I usually give it just twice per day, and continue on the azopt does not have continue to ask the patient to continuously put eye drops. Azopt eye drops is not harmful for the patient. It is not found to have any side effects, and so I ask the patient usually to continue using the eye drops for a long time. For more than 1 year old, I usually give a loading dose, use a loading dose. I advise with azopt eye drops for the patient to put the eye drops for 3 times per day for 2 weeks, and then to continue on just 2 times per day. I check my patient first after 1 month, and then I check the patient after that every 2 months. In every case, if it was possible, I check the visual acuity in every case, and that's everything. It's my regimen.
Thank you, Dr. Heba. Dr. Zainab, will you use azopt?
I didn't use
Afterwards,
it
I mean.
but it's a good advice. I think I will I will take it in my consideration. As Dr. Heba said, it has a good results with hair, so why not? It's harmful. It's harmless.
Harmless,
Yeah,
yes.
harmless.
Thank you, Dr. Zainab. Thank you so much. Thank you, Dr. Heba. Thank you, Dr. Ahmed, for the great.
Let me say just one final comment on one of the questions of the audience, because one of the audience was asking about the regimen of the Kestenbaum, or how we judge the amount of our resections in the Kestenbaum surgery. First of all, you evaluate the amount of the abnormal heat push, whether it is you have a mild angle or moderate angle or severe abnormal heat pusher. In my regimen, I measure it by prisms. I put prisms in the clinic against to neutralize the deviation, as if the patient, if the patient has a left face term, and so this his right eye as if exotropic, and so I put a base against the right eye and increase the prism power until I had the abnormal heat pusher of the patient corrected, and then I divide the prism power by 2, and I got out the angle of the abnormal heat pusher. Okay, and then I decide whether it is mild, moderate, or severe. We can make modifications on the tables actually if the patient had esotropia or exotropia in the primary position. We can increase or decrease the recession and resections to help correcting the strabismus with the abnormal heat posture. But in all cases, you need to counsel all your patients that you might need a second intervention, because even with the Kestenbaum, the regular Kestenbaum, when you measure your angle of abnormal heat posture and you choose the right lateral rectus recession and resection, you might have postoperative deviation in the surprising deviation in the primary position. And so in all your cases, you need to counsel the patient about the need for another intervention. Not all cases are very, very excellent, like Dr. Salah case actually, and have a this very good results, but you might find surprises after Kestenbaum surgeries actually. Thanks for your order.
Dr. Heba, we have a repeated question from the audience. Dr. Hosni Hassan and Dr. Amal Al-Humaydan asked the same question. They asked about the mechanism of azopt.
The mechanism of azopt is not, till now, it is not well determined. It is not well described. Even you might search in the literature, you will not find even a single one sure answer. The common answer of this question is that the azopt eye drops acts on improving the foveation of the image and improving the function of the ganglion cell layer. It's everything about the mechanism of the azopt described. Till now, it's not well proved what is the exact cause of this good results after azopt. Yes.
Thank you, Dr. Heba. Thank you, Dr. Ahmed. Thank you, Dr. Zainab. Thank you so much, Dr. Zainab, for the nice cases of your fellows. One of the attendees asked about how can he get back this event. So I will share the link of our page. Okay. This is the web address of our page. Can you see it?
No.
It was here and then it's gone. Yes.
It appears, Dr. Mustafa. Well, just Mustafa, please tell them about the YouTube channel, because many countries are not interested too much in the Facebook. They are interested more in the YouTube channel. You can find our YouTube channel, and all the videos will be uploaded on our YouTube channel, inshallah.
Inshallah. Thank you, our panelists. Thank you, our speakers, and thank you, our attendees.
Thank you.
And good night.
Thank you.
Thank you, Dr. Mustafa.
Thank you, Dr. Mustafa.
Thank you.
كريم كده
Hello,
خلاص.
doctor. Greetings from Orchidia Pharmaceutical. I hope you, your family, and all your beloved ones are safe and in good health. Based on your trust in FortiMox in managing ocular bacterial infection and post-operative cases, today I'm going to talk about the outstanding and unique combination FortiMox Plus, which is prescribed for ocular surface infections combined with inflammation as bacterial conjunctivitis and lid infections as chalazion, stye, and blepharitis. Also, FortiMox Plus is the safest combination because it's a self-preserved ophthalmic solution with less side effects on IOP. Thank you for your time.
Thank you, Dr. Ahmed.
Thank you, Dr. Zain. Dr. Ahmed Bey.
ثانك يو
خلاص
يا جماعه. احنا مضطرين ان احنا نقفل، احنا لسه اون اير، فاحنا ثانك يو على كده وهنقفل.
يعني احنا كده مش هنكمل بعض، مش هنكلم بعض، خلاص هنخرج كلنا.
لو حضرتك عاوز نعمل جروب تاني نتكلم فيه مفيش مشكله، بس مش هينفع نكمل كلام هنا.
طيب. طب نعمل